I had the opportunity many years ago to go to the camp and hang out with so many wonderful young people and to talk to them about the opportunities in the healthcare field. And as Bea said, Mrs. Walters said that she and I have become very close friends, and I know that the AnBryce Foundation is so dear to her heart, and therefore it has become dear to our heart, particularly at Morehouse School of Medicine. So I would like to share information with you, but want to make sure that I give enough time also for lots of questions, because I know people have lots of questions, and it has been just a pleasure to be able to share with people important information where people can ask any type of question. And that's what I would encourage you all to do. So I'm going to start out.
Can I say something first?
Yeah.
I'm sorry to interrupt you,
Yes.
but I wanted to say that why don't you say something about how you, first of all, you took the vaccine nation. I mean, it was like everyone saw it in the nation. You were on. You can further discuss that.
Yes, yeah. So I will start with and you've seen my bio, but one of the things that I am and have always been is a clinician scientist. So most of my work early on in my career was actually in women's health doing clinical trial work. So I started the first clinical research unit at the University of Kansas early on in my career. And then I started the Center for Women's Health Research at Montgomery, which was the first center that looked at diseases that disproportionately impacted women of color. I also served on the FDA advisory panel for 8 years, looking at urological and reproductive health drugs, and also have served on NIH Council, et cetera, for 25 years at least. So I have a lot of experience with clinical research, and particularly clinical trial research. So one of the things that really happened for us early on when we saw how disproportionately impacted Blacks were with this virus, Black and brown people with this virus, we wanted to make sure that we began to address much of the distrust and mistrust that was in the community between Black and brown people in the healthcare system, regardless of a vaccine, right? But just talking about clinical research, and why would I actually even think about participating in a research trial when we have not necessarily been serviced as well by the healthcare system? So we started with multiple town hall meetings, you all. We probably, the Black Coalition Against COVID, blackdoctor.org, the National Medical Association, the National Black Nurses Association, the National Urban League, and the 4 historically Black medical schools. We have now done 8 town hall meetings with 25 to 30,000 people on each of those town hall meetings to address mistrust, distrust, whether or not you should participate in a clinical trial for a therapeutic to treat COVID or a vaccine. And then, as Mrs. Walters talked about, I actually took my vaccine on my vaccination on national television with Sanjay Gupta at 7 o'clock on CNN. And a part of that was, first of all, I'm not 65, so I was jumping the line, but we made a decision that that was important to do because we needed to instill confidence that clearly Sanjay and I would not put something in our body if we did not believe it was safe. And we are concerned that Black and brown people who are feeling this mistrust and distrust would not take the vaccine. So I want to talk a little bit about, give a little bit of science, and then I want to talk about some of the myths and challenges that we are seeing, if that's okay. And so as Jalicia brings up my slides, please, and I don't have a lot of slides, but I think pictures are worth 1,000 words to me. And so I'm going to try to see these pictures that she's bringing up, okay? She has them there, great.
Can you see them?
I'll be fine, yeah, I can sometimes say I'm fine, all right. So when you look at this first one, and I think this is important, stigma. The first thing we want to recognize is that this virus does not discriminate. Okay, so it doesn't care if you're black or white, brown or blue. If you are in contact with the virus, you are going to potentially become infected. The reason that we see black and brown people having more cases is because they cannot socially distance, they live in multi-generational homes, and they do not have the luxury of working from home, etc. We are the essential workers. Now, the data does show, though, if you wear a mask, particularly if you wear even a double mask, and you keep away from people 6 feet, and you wash your hands, you can mitigate your ability to contract the virus by about 90%. We also want to make sure that people go to reputable sources for their information. The Centers for Disease Control, your Department of Public Health are the right places to go for information. We also know, particularly as we have looked at this virus and the vaccinations, that people were getting a lot of information, and now we're beginning to see people have conversations about vaccine hesitancy, which is translating to, well, black and brown people don't want to take the vaccine, so should we even worry about distributing it to their communities? That is discriminatory, and we are making sure that that's not going to happen. And then we want to make sure, you all, that we continue to show compassion and support for people who are impacted by ensuring that they have many of the social services needs that they have taken care of when they come into contact with this virus. Next slide, please. I wanted to put this in here because I wanted people to know that there is no reason why you shouldn't wear a mask. So I really, I looked at this survey and I said, all these are the reasons that people talk about not wearing a mask. It is not an option at this point. And I think that if you look at the latest data, what you're seeing is that in most parts of the country, about 75% of people are wearing a mask. So whereas we have been doing surveys on this, we are beginning to see a shift with people wearing masks. Next slide, please. Let's talk a little bit about this virus. This spike protein that you see right here, it is what allows the virus to get into the cell. It gets into the cell, and it gets in through a receptor called the ACE receptor. And that ACE receptor is on most of your vasculature. So in your lungs, in your kidney, in your heart, those are the places where it causes most of the damage. And most of the vaccines are trying to block the entry of that spike protein to getting into your cells. Okay, just remember that. That spike protein is very key. Next slide. Now, here's how you get the virus. This is how you get it. Someone coughs on you. You touch someone sneezes on their hand, and then they shake your hand. Or the least of which is the virus is on a surface and you pick it up. And this is why the 3 W's are so important. Wearing your mask, you can see for number 1, washing your hands, watching your distance. These are the things that make a difference in beating this virus. Next slide, please. The death rates are highest in older people. And so you may have asked yourself the question, why is it that they were offering the vaccines to an older population before they gave it to a younger population? Well, if you think about people in long-term care facilities, they only accounted for 1% of the population, people in long-term care facilities. yet they accounted for greater than 6% of the hospitalizations and greater than 40% of the deaths. So it meant that when an older person in a long-term care facility was compromised due to the virus, they had a significantly higher chance of dying. And the benefit of the vaccine begins first with decrease in deaths, then hospitalization, and then cases. Next slide, please. Now, if you start to look, though, at African Americans, you can see that they are disproportionately impacted. And this is just looking at it by some cities. So let's look at the state, of Louisiana. 32% of the state's population is Black, yet they account for 70% of the COVID-19 deaths. That's what we mean by a disparity. When you have a difference, that type of difference in the percentage of people who are dying, that's significantly higher than the percentage of people that are represented by that race or ethnicity in a city or in a state. And you can see that across the board. Next slide. So what happens when I get the virus? I become sick. I feel like I got the flu. And for a lot of people, you just feel like you have the flu. But for those who already have diabetes or hypertension or heart disease or obese, it has a much more severe manifestation. Next slide, please. And you can see the cascade of things that happen. And one of the things that you heard people talk about was an inflammatory burst. And that is the thing that happened when there were a lot of inflammatory cells that overwhelmed the system. And that's when we started to see people get intubated. And those are the people, 5%, who are critical. Their lungs, they have a picture on their x-ray that shows that they look like they have a really severe pneumonia, and they have to be intubated. And unfortunately, if you get intubated, that means that you have a much higher chance of dying. Next slide. Again, I want to point this out, that it's not just Blacks who are disproportionately impacted. Hispanic or Latino, and look at our American Indian or Alaska Natives, disproportionately impacted by this virus. 281 deaths per 100,000 in American Indian and Alaska Natives, compared to 53 per 100,000 in whites. That's what we call a disparity, you all. Next slide, please. Again, I want to point this out. When we look at deaths, we see a higher percentage of deaths in the Black community, followed next by Indigenous population, followed next by Hispanic and Latinx. Next slide. And again, I want to point this out. And the reason I'm showing this is because as a scientist, when we see these type of gaps based on the percentage of people who are in a population and they have a significantly higher death rate, look at 35 to 44-year-olds, you all. Look at the ratio in the blue here for white deaths. Look at the ratio for Black death. Look at the ratio for Hispanics. So regardless of the age, we are seeing Black and Hispanic, Latino being disproportionately impacted. So that tells us, you all, that we have to have special attention to our community. Next slide. Let me just address this herd immunity, okay? When a novel pathogen like SARS-CoV-2, so we've never seen, that's why we call it novel. It's not that we've not seen the COVID viruses, coronaviruses, but this one is a new one. When it is introduced into a community, nobody has immunity to it. Nobody has produced antibodies. So it gets introduced, okay, that's what you see here in the little red with the spikes, and it's infecting people. There will be people who recover, okay? Recovery and those who receive a vaccine, those people develop immunity for a period of time. Now, what we don't know is how long those antibodies stay around. And over time, the pathogen cannot find new hosts. In order for us to get to this with COVID, with this type of virus, we think that anywhere from 55 to 82% of people would have to be infected. The challenge with this, you all, is how many people will have to die in order for us to get there. That's why herd immunity is unacceptable without a vaccine. Next slide. Again, I keep putting these reminders in here because these are the things that matter. And yes, there's data now that's showing that some masks are not as good as others. But what I would say to people, any mask is better than none. And the data now shows that 2 masks are better. And particularly if both people are wearing a mask, you can see the contagion probability goes down. You see that? Now, let's talk a little bit about vaccines versus antivirals. Next slide. Next slide. Right, okay. Vaccines versus antivirals. Vaccines are the prevention, what we're trying to do to prevent you from getting the disease. Remember, the disease doesn't occur unless you have the virus. So it's not necessarily preventing you from getting the virus, but it's preventing you from getting symptoms and then hospitalization and then dying. Antivirals are what we use to treat you when you are starting to have symptoms. Next slide. Again, how does a vaccine work? Typically, what happens with a vaccine, it is an inactivated or weakened form of the virus. Remember that spike protein. What has happened is we've been able to, scientifically, understand the genetic code for that spike protein. And so they've been able to now make a vaccine against that spike such that it cannot enter the body. Okay, so it can't get into your cell. Once that happens and you start to produce antibodies, okay, against that, you now have antibodies against that protein that's preventing the virus from getting into your cells, and eventually it wears down the virus. And I always kind of think about it like a Pac-Man eating up that virus. The reason that you need that second shot, though, you all, is that you need to remind your system of this virus. And so that second shot, first shot causes neutralizing antibodies. That second shot goes and wakes up your long-term immunity, your T cells, that causes your body to remember that pathogen or that virus the next time it comes into play. If you think about, and I think I have some slides on this, next slide, please. This is not new. How many times do we take the measles vaccine? Once. pertussin once, mumps, rubella once. And the reason that's the case, you all, is because those vaccines wake up that long-term immunity, that T cell. So if your body were to come into contact with measles, mumps, or pertussis, or rubella, your body remembers it because it's gone and impacted the T cells, and it has long-term immunity. Now, we hope this will be the case with this vaccine, but we don't know yet. We don't know the answer to that. Again, next slide. There are lots of antiviral drugs that are out on the market that are being able to reduce people getting intubated and people dying. You heard of remdesivir, you've heard of corticosteroids, you heard of hydroxychloroquine, and all of the stuff that our former president was talking about that didn't work, that did not work. Okay, that did not work. But those other medications have shown some benefit. Next slide. Let's talk just a little bit about the different types of vaccines, okay? So the one that you hear the most about is messenger RNA. And that is the Pfizer and the Moderna type of vaccines. That technology, you all, has been being developed for the last 15 years. It just so happened that it was ready for prime time when this virus hit the system. They were able to figure out the genetic code of that spike, and what they were able to do was wrap it around some lipids and some other things, inject it into your system. And what that has in it is the instructions for how to make a protein that is seen by your body to then produce the neutralizing antibodies. Typically, and you'll see this with the Johnson & Johnson one, sometimes they use an adenovirus, another type of virus, to carry that genetic information to the cell, to the inside of the cell. The messenger RNA goes directly there itself, so it doesn't need a carrier. And then you'll hear about the Novavax. Novavax has a protein base where it actually stimulates antibodies against a part of that spike. And it actually does it without having to use necessarily the messenger RNA process, okay? So the key thing is, and this is a good thing, that there are lots of different vaccines in play. That's a good thing. And they all pretty much work very good, very well, I should say. And then just next slide, and I won't go into a lot of this. Next slide, please. Okay, here, okay, so I must have skipped that. Okay, so here's the types of vaccines that you've heard about, okay? These are the ones that we are used to in our bodies already. The good thing about the coronavirus vaccines, they are not live vaccines. So you cannot get coronavirus. You cannot get it from taking the vaccine because it's not live. And remember, it's just the genetic code part of that spike. Next. Just briefly on the clinical trial, just so that you know that, because you've heard people say warp speed. And people think that there were steps skipped. I have looked at the data for multiple clinical trials and for at least 3 of the vaccines that are being developed. Pfizer, Moderna, AstraZeneca, I guess I saw the Novavax also, and some of the Johnson & Johnson. There were no steps skipped. What happened to get us to this point of being able to have a vaccine developed in 6 months was that we used the power of private and public partnerships. So on the private side, you had these companies that were developing this technology for messenger RNA. On the public side, which we pay for with our taxes, you have the National Institutes of Health that had an infrastructure in place already to do multi-site clinical trials. They combined both of those resources to be able to enroll 30 to 40,000 people in a trial. Previously, there would have been all type of agreements and all type of things that had to be discussed, not about the science, but about the process. So we finally, for once, used the strength of public-private partnerships to get something done in an efficient and effective way, but no steps were skipped. Next slide. Again, this is just showing you that much of the benefit of the vaccines happens inside of the slides, of the cell, and also the treatments happen inside of the cell where they're really trying to kill the virus. Next slide. You have heard about anti-vaxxers. There are people, you all, who will never believe in vaccines. But I will tell you, if we did not have vaccines for measles, mumps, rubella, all of those diseases, smallpox, that have wiped out people, then we would not be the people that we are today. We would not be the country that we are today. And so I listen to people, I try not to discredit people, but I am telling you, the science is real for how these vaccines are impacting COVID, and we're already beginning to see that. Next slide. This just shows you that many of us have gone back and looked at all of the processes to make sure that there were no steps skipped in this vaccine development. Much of it was more quiet, but there were no steps skipped. If you look down in the bottom, you can see what R&D, the phase 1, phase 2, phase 3, manufacturing and distribution. And what you see is many of those things were being done concurrently. So let's take for Pfizer. When Pfizer started their phase 3 trial, they started producing the vaccine at that point. Now, they didn't know that it was going to necessarily work as well as it did. They had good phase 1 and phase 2 data to show that it was about 90% effective in the phase 2 studies that look at safety and efficacy. But they decided to take a bet and start manufacturing it at that time. If they had not done that, you all, because it takes from the time they start to the time a vaccine is ready, 120 days. They just announced yesterday they've gotten it down to they're halving it down to 60 days. If they hadn't done that, guess what? We wouldn't have as many vaccines as we have now. All right, I think I'm almost done with slides, and then I'm gonna just answer questions. Okay, this is not me. This is another person. I think this is the first person who got the vaccine in Texas. And she wanted to do this again to really build confidence. And I think it's important that we do that. So with that, I'm going to stop and answer questions. Answer questions, hopefully. All right. Hello?
Any questions?
I have a question. This is Brian Welters. Hi, Dr. Montgomery Rice. Thank you for the presentation. what do you say to people that have seen individuals like yourselves and others, and maybe unfortunately some older individuals who've gotten the vaccine and then subsequently have passed away recently thereafter, towards some of the people you talk about with anti-vaxxers? And when I look at some public figures, like I just saw the NBA players were asked as public figures to take said vaccine to continue to show the efficacy of it. What do you say to those individuals to bring some comfort that these are beneficial?
Thank you. Very good question. So unfortunately, people still die, and it has nothing to do with the vaccine. And I have a lived experience of this. I am very close to Hank and Billy Aaron. They are very close spirits, kindred spirits of mine. And when we were at Morehouse School of Medicine, getting access to the vaccine, we were approached by Ambassador Young to ask us to help in building vaccine confidence. And so you all may have seen that on January the 6th, we actually vaccinated 30 of the civil rights leaders to build confidence. So Ambassador Young, Hank Aaron, Mrs. Aaron, Ms. Clayton, former Secretary Louis Sullivan, and a host of other people. They are all 75 and older, and they all believe in science. And I had already taken the vaccine. And they have all done well. Now, 2 weeks later, Mr. Aaron unfortunately passed. Mr. Aaron passed in his sleep. How do I know that? Because I was the first person Mrs. Aaron called. And I was there. And it had nothing to do with the vaccine. And so what I say to people, Brian, is that people are going to die normally, unfortunately. And if you're going to have a reaction to the vaccine, it usually is going to occur within 72 hours. And most of it is sort of like an allergic reaction. But we have not been able to tie any other untoward events other than mostly allergic reactions to the vaccine. And then what I say to those who are hesitant, and I said this the other day, if you're in line waiting to get your vaccine and you're hesitant and there are a bunch of people behind you, step aside. Let the other people come ahead of you. And what we're going to do, though, we're going to save your vaccine for you. Because we believe that this is one of the important ways to mitigate this virus. The virus is doing what viruses do. It's mutating. And what we have to do is to get fewer people who are going to be infected so that we can control the mutation also, because this is just what happens with viruses. Okay?
Thank you.
You're welcome.
Dr. Montgomery Rice, this is Sarah Kavinsky from Notre Dame. I was wondering, I know that vaccines grow in efficacy the more people in an area that take the vaccine. So it's one reason why you did it they did it at nursing homes and that sort of thing. Do you foresee a time when we might move away from ages and into really concentrated zones, like say colleges or specific communities in New York, to just increase the efficacy because more people in a zone have it as opposed to people scattered out based on their age?
Yes, so thank you, Sarah, for the question. I think if we had not seen the disproportionate number of people who died in nursing homes and that age progression of the older you were, the higher your chance of dying. But remember, all of those people most likely had already some compromised vasculature system, right? And so the virus was more readily able to destroy their vasculature and get into their cells and cause this damage because they were older. It had nothing, it's just the fact that they were older, okay? And so I think if we had not seen that, we would not have put all of the age restrictions on it. But what our goal has been is to reduce deaths. Then you're going to see hospitalizations. Then you're going to see cases. And that's exactly what we're seeing. We have seen a downward trend now in deaths, and we're seeing a downward trend in hospitalizations. And eventually we will see a downward trend in cases because we will have people who are vaccinated, even if they get the virus, their viral load will be so low that they won't be able to pass on the infection. Now, the president announced yesterday that it is his hope that we will have 600 million doses by July. That doesn't mean we're going to have 600 million people vaccinated because it's just a vaccine. It doesn't become a vaccination until you put it in your arm. So we are going to have much more targeted discussions with people so that those zones that you're talking about, Sarah, will be receptive. That is why conversations like this are so important. And it's also important to say to people, when we don't know the answer, you all, we actually don't know yet. So we do not know, you all, how long the antibodies hang out. We do not know how long that is. That's why clinical research is so important. We do not know why people are having these, what we call long haulers effect. So they had COVID, they didn't even have a bad case of COVID, but yet they still are having respiratory problems. They still are having body aches, etc. This is why research is so critical. So I do believe that once we get to a significant number of older persons who are vaccinated, and we see, and no one has given a target yet, but as we continue to see the decrease in the number of deaths and hospitalization, many of us are pushing for them to loosen the age restrictions and to start doing stuff like vaccinating the teachers. Okay, now, so let's just say that vaccinating the teachers, what is it, 3.7 million teachers in K through 12, or something like that. Okay, that is a lot of people to be vaccinated. Let's say that 50% of them would agree. The key thing is, you all, it also builds confidence. It also builds confidence. And yes, while it may be a low chance of you in a school district getting infected because you're wearing your mask, you're washing your hands and watching your distance, those teachers need to feel confident also. It's sort of like, why are you doing temperature? Because I think doing temperature is a waste. However, and the data does show that it doesn't really correlate, but it provides people with a level of confidence and it reminds them to do the other things. So many of us continue to do the temperature because it reminds you to wear your mask. It reminds you to wash your hands, etc. And so part of it is psychological also to help people be more comfortable. And I think teachers deserve to be vaccinated. I think they ought to go to the front of the line, but that's just me.
I agree too. Thank you so much.
I have a question.
Yes.
Dr. Rice. Right now, Moderna and Pfizer has a vaccine for, I guess, young people above the age of 16, I believe. You can validate that. When do you think vaccinations will come out for kids younger than that, or young people younger than that?
By the summer. So there are 2 trials that are going on right now. So Pfizer and Moderna have trials in certain cities going on for kids who are 12 through 18, I believe it is.
Okay.
So they have 2 trials going on right now because one of my girlfriends in Atlanta just enrolled my godkids in the trial. And I think they got Moderna. So there are trials going on right now. There's nothing right now. There's nothing that indicates to us that it's not going to be safe in kids. But we do need to do the study, because that's why we do research, right? Because we're looking for unanticipated side effects. And it's better to have an unanticipated side effect in a clinical trial where you can control it versus just assuming. Like for many, many years, people assumed that whatever drug worked in a man would work in a woman. And then they started to figure out that there was differences in the size of blood vessels, et cetera, and they're not always the case. And so I think by summertime, we'll have that data. And my hope is that by the fall time, we would have young people getting vaccinated, because we'll definitely have the data by then. But 2 major trials are going on right now. And I also will say that there's a trial that's getting ready to launch next first or second week in March, which is going to be for college students. So we're enrolling 20,000 university students between the age of 18 and 26, I believe it is, at 22 sites around the country. And those students, all of them will get Moderna, and half of them will get it at the beginning, and then another half will get it 2 months later. And there's going to be a lot of contact tracing, and they'll do some sub-studies with this persons that they've most been in contact with. And we'll look at them, because we're trying to look at what happens with asymptomatic spreaders and what happens with people who shed. Because you can still have the vaccine, become positive, but you may shed the virus at a different rate. And so those people will be swabbed every day, and we'll be tracking that. And so it's about a 5 to 6 month study, and it starts the first or second week in March. So if you are 18 to 26, there's an opportunity for you to participate in a trial that is going to be very important for young people.
Dr. Montgomery Rice, we have some questions in the chat.
Okay.
So we have Mr. Roberto Gill Jr., who has asked Dr. Rice, how do we help communities that are distrustful of the government or medical system? For example, I've seen lots of references to the Tuskegee recently on my social media feeds.
We do just what we're doing right now. We have conversations. We're not dismissive. We don't try to shove it under the rug that Tuskegee happened. The Mississippi appendectomies happened. Henrietta Lacks happened. All of those things are real. However, what we have to be careful about is that we cannot let our history lead in our future. It's a foundation for us to understand what happened, but it cannot necessarily be what forges our future. Because we know, you all, the data shows that we are Black and brown people are disproportionately impacted by this virus. And what I and other scientists and leaders have done is make sure that we are in the room. We have been involved with every stage of this vaccine development. We are involved in all of the clinical trials, you all. We have a trial going on right now with looking at people with sickle cell disease, sickle cell trait, diabetes, heart diseases, sarcoidosis. So we're looking at this, and we're looking at these diseases that disproportionately impact people of color, so that we can understand, are there unanticipated side effects that are going to happen when they take the vaccine, such that we can begin to mitigate those unanticipated side effects. And so I think what we have to do is continue to have conversations with people and to assure them not to be dismissive. And then again, also affirm for them that when you are ready, we will be here with your vaccine. Because I am convinced that we're going to need about 70% of the population to be vaccinated before we will actually see a significant drop in cases. Do you want, I can see the question. Do you want me to start answering them? Is that okay?
Yes, please, Dr. Rice.
Okay. Do you think the vaccine can still be effective for people with rare autoimmune diseases taking immunosuppressive drugs? There is data that's showing that it is still effective. I would say you need to do it under the care of your provider. There are people who are on chemotherapy, et cetera, who are taking the vaccine. And so you need to do it under the care of your provider. And you would be one of those people that you would be observed for 30 minutes to an hour afterwards to see if there's a side effect, et cetera. So yes, we definitely are giving it to people who are immunocompromised. We're giving it to people who are on chemotherapy drugs, et cetera, because those persons actually are more susceptible to actually getting significant symptoms and complications when they get the virus. Same thing with pregnant women. So there's a lot of controversy here about whether or not women who are pregnant should take the vaccine. Now, I'm an OBGYN, reproductive endocrinologist, and fertility specialist. And I am very much aware of the caution that we always have about enrolling pregnant women in clinical research. But the data is showing us that pregnant women are having worse side effects and complications with COVID compared to age-matched women who are not pregnant. And so we are recommending the vaccine. ACOG is recommended, American College of Obstetricians and Gynecologists, for pregnant women. We're typically doing it after 12 or 14 weeks, but we are definitely recommending it. And I believe that there is some data that right now, as we're looking at whether or not it is in your breast milk, that it can be there, but we don't necessarily believe that the vaccine causes a problem if it is. Do you think that the discovery of different strands of COVID that we'll be looking at an annual vaccine, like the flu? I do believe that we are going to have boosters. Yes. Yeah. And we don't know yet. Remember, the first person got vaccinated, in December? Early December or late November, something like that. And so we're just, you all, getting to the point where we almost have 6 months to know whether or not how long these antibodies are going to hang out. And so I am concerned about the different strands. And so one of the things that we're doing is that we are starting to sequence, so that when someone is positive, we're starting to sequence in different parts of the country. We're doing this at Morehouse School of Medicine. We'll be doing it in all of our vaccine trials. We're sequencing if somebody turns positive after they've had the vaccine to see if they had a different type of strain. So we're looking at all of that. You're required to take 2 doses of the vaccine 3 weeks apart. What happens, or how effective is the vaccine if a person shows up 6 weeks thereafter? The answer to that, Ms. Patton, is that we actually don't know that answer yet. We will find out, though, because people are not sometimes having the vaccine available. There have been people who come in for their second vaccine and it's not available. And then there have been some people who, for some reason, missed their appointment. And so we will be looking at it. So one of the things that happens, you all, whenever a drug comes onto the market, is there's something called a phase 4 study usually. And those are observational trials, right? So you ask people to sign up. So if anybody's gotten the vaccine, they know that they also signed up for something called VSafe. And VSafe sends you information every day or every 2 days or once a week and then twice a week, and then it starts to space it out. But it's asking you questions about what's happening with you. Have you had a positive COVID test? And then if you were to probably say yes, then it would probably ask you to come in and give a blood sample, et cetera. So they are tracking this over time, and that's going to end up giving us observational data. And we'll learn a lot more from that. Okay. Considering that Black and brown young people are apprehensive about taking the vaccine once it's available, how would you propose that we act as advocates for the vaccine to our peers? Great question. Again, pointing them to trusted sites for information, having small group discussions. There are a lot of people in the community who are versed on vaccines and why you should take them. And I think really small group discussions so that people are not intimidated to ask questions and to voice that they are afraid. And then to be truthful with people. When you don't know the answer, you don't know the answer. That's why we do research. But what we do know, you all, is that we're now at 470,000 people who are dead. They're projecting that we may have another 150 people dead by summer.
150,000. Yeah, 150,000.
150,000 more dead by summertime. All of those are people that we know. That's somebody's mother, that's somebody's father, that's somebody's sister, that's somebody's brother, aunt, friend, loved one. And so if there's something that we can utilize to stop the deaths, it's not perfect, because you still got to wash your hands, wear your mask, and watch your distance, because we still know that you can still contract the virus, and therefore you can still pass it on to someone. And I just think we just have to keep having conversations. And I'm just going to keep talking about it as much as possible. Now, let me bring up one thing that this is going to become an issue. You've heard about the different levels of effectiveness of these vaccines, right? So you heard Moderna and Pfizer, 90-some% effective. Let me make sure everybody understands what that means. It doesn't mean that 90% of the people were prevented from getting the virus. It means that when you looked at symptoms, hospitalizations, and deaths, and really looking at the severe, what we call severe symptoms that get you hospitalized and dying, if they were effective against that. Now, you've heard with Johnson & Johnson, which is a one shot, that it was only 66% effective in protecting against COVID, meaning that you didn't have any symptoms, etc. But when you start looking at the gradients of disease, it was 85% effective against that severe disease that got you hospitalized. So lots of people are concerned about, they're going to start pushing Johnson & Johnson over to minority communities. Okay, have any of you all heard that? They're concerned about that. Now, to my knowledge, there's no scheme or plan for that to happen. However, people are going to probably be more receptive, to only taking one vaccine versus two, right? And so this is what I say to people, is that something is better than nothing. Just like one mask is better than two masks, right? I mean, two masks is better than one mask, but if I could only get you to wear one, I would do that. We will most likely, with all of the vaccines, be taking boosters or additional vaccinations. So if Johnson & Johnson gets approved, I'm going to recommend that if people have the option to take it, and if that's the only option they have, that they should take it. Because the data, I believe, is only going to get better with time, showing that it is effective for severe diseases. Remember, what you're going to see is deaths go down, hospitalizations go down, and eventually cases. But you got to get that viral load down low enough such that you cannot pass the virus on to the next person. And I think we're going to see a slight difference with Novavax. In the phase 1, phase 2 trial, Novavax was about 80-some% effective. Now, statistically, is there a big difference between 82% and 90%? Probably not. It probably means only one additional person versus two additional persons. But we got to make sure that we understand that all of these vaccines have been shown to decrease deaths and hospitalization. So I wanted to make sure that you all heard that from me. Yeah.
Thank you,
Ross.
Dr. Montgomery.
I have a
Sorry,
question.
I think we had a question from Miss Brenda Thompson.
Yes. Hi.
Thank you for that wonderful presentation. But I have and I've learned so much. I have two questions. With regards to accessibility, I have found something interesting with my white friends and my Black friends, that the network among so many of my white friends knew where to find the vaccine. It's not the hesitancy of taking it. It's that many of the people I know can't even find it. So that is the frustration. I can, now many of my friends are beginning to find it now, but early on, no one knew where to go. And the second question is, what is a caretaker? I understand that a caretaker is someone that comes in your house if you're invalid, but people are getting children vaccinated, and I just don't know, what do you think that is, so that we're not circumventing the wait list to get the shot?
So thank you for that question. Let me just say that, and I'll give you this prime example, and this is real. So we announced on January the 6th that we had just found out from the state. So first of all, the state of Georgia, you all, the vaccine became available. Christmas Eve was when we had to do all the paperwork in order to get access to the vaccine. That's how fast things were moving, right? So this is what we were doing over Christmas. And then January the 6th, we got the first dosages, and we wanted to do this with the civil rights leaders. We announced that we would have 500 vials, 500 vaccines for 500 people, and we were going to start vaccination Saturday. We announced it at 12 o'clock on whatever the 6th was. Our website, we had to shut it down because within 48 hours, we had 2,000 people signed up. That morning on Saturday, now we're in the West End in Atlanta, get off of Lee Street right there, okay? We had 20 was backed up. And when you rode down there, it wasn't Black and brown people. It was mostly Caucasian people. Because they figured out access faster than Black and brown people. And they had many more of the tools. Now, we didn't turn anybody away, but we probably vaccinated 40% white people that day compared to the 60% of people in our community. But we didn't turn anybody away. Now, what we did the next time we opened it up, we put down that you had to have a preference of Fulton County residency. And we were very intentional about this. We got on the news and we said it, etc., because we were trying to be a resource for our community. And now we're getting ready to go to we use our mobile research vans, and we've been going to senior citizens' homes and long-term care facilities and actually vaccinating people in their places. And Brenda, if we are not intentional about this, what will happen? So you look nationally, 7% of the people who get vaccinated are Black compared to in certain areas. At Morehouse School of Medicine, we're 70% of the people who get vaccinated there are Black. But that is because we've been very intentional about how we are directing the resource. And I think that is nothing wrong with that. I am speaking very broadly about it. I'm about to lead the state of Georgia's COVID equity task force because we got to make sure our rural citizens are not left out. People who don't have access to cell phones, people who don't have access to many of the other tools, we got to meet them where they are. That is our responsibility. Now, this caregiver, we've seen people try to go around the system, etc. And Grady initially tried to say that if you were in the car with someone who was 65 and old and you said you were a caregiver, then they were going to vaccinate all those people. They only got to do that for one Saturday because people started to bring 6 people in the car and say that they were caregivers. And so what we need to do so that we don't have to worry about rationing is increase the production. and then increase the access such that it's 24/7 that you have access. And I think that's what the president is trying to do. If we get 600 million doses, everybody who wants to be vaccinated should be able to be vaccinated.
Good question. No more questions? Because
We have some more in the
So there was one question that said there is a vaccine for COVID in such a rapid time, but we are still waiting for a vaccine for HIV. And the reason for that, you all, many of us have been working on a vaccine for HIV. The HIV vaccine is much smarter than the COVID vaccine. I mean, the COVID virus. The HIV virus is just much smarter. It mutates a lot faster. And what HIV does, it goes into your system and it steals your proteins. And so it has a different genetic code almost every time in everybody's system. And that's why we can't get a vaccine to HIV. It's much smarter than COVID. COVID actually mutates a lot slower. That's why we're keeping our eye on these variants. Okay. I don't see any other questions.
no other questions?
I don't think so.
You want to say something, Jay?
Yes, I definitely, I want to thank everyone who has joined us today. This has been incredibly informative, and I know that so many people probably have many more questions. I am not at all going to make any promises because, you know, Dr. Montgomery Rice, she volunteered her time to us, but I think that at least what we can do is as things change, we can, you know, stay as informed, whether you are getting information from us through, we tend to send out a weekly resource guide. So leveraging the AnBryce resource guide, we may even potentially include a section in our newsletter. And we want to stay as current and have as much available information as possible because information is changing at a rapid rate. I want to thank Mrs. Welters, Mr. Welters, and the Welters family, as always, for providing this opportunity for all of us to stay educated, to stay informed, and also to stay healthy.
I have a question, Dr. Rice, real quick. Some of those slides that you showed today, if anyone wants a copy of them, can we give them
so
to
Jay, we'll
distribute them?
work with Nicole and we'll get you some of those slides if anybody would like to.
Thank you, we appreciate it.
I see a lot of people that I know, well, and probably everyone I know. I'll just say, hi, Brenda Thompson. You know why I'm saying hi to you. But anyway, and everyone else. It's been, have a great Saturday. Thank you very much.
Right.
Thank you, Jaleisha.
Thank you.
Bye-bye. Have a great one.
Okay, bye.
Bye-bye.